Neck pain management, a comprehensive approach. Neck pain is a significant musculoskeletal condition affecting millions worldwide, impacting daily activities and quality of life. This presentation explores comprehensive management strategies, including detailed investigations, warning signs, treatment approaches across different phases, and evidence-based interventions. We'll examine both pharmacological and non-pharmacological options, providing specific guidelines for optimal patient care. Understanding and managing neck pain through evidence-based strategies. Understanding neck pain. Neck pain is a common musculoskeletal condition affecting up to 70% of individuals at some point in their lives. It is characterized by discomfort or pain in the cervical spine region, ranging from mild stiffness to severe, debilitating pain. This condition significantly impacts daily activities, work productivity, and quality of life, often leading to reduced mobility, sleep disturbances, and potential psychological distress. Investigations for neck pain, comprehensive physical examination, and diagnostic imaging studies for accurate assessment. Physical examination. Assess lymph nodes, active cervical range of motion including flexion, extension, rotation, and side flexion shoulder assessment. Screen shoulder range of motion. Perform full examination if abnormalities detected. Neurological testing. Evaluate upper limb reflexes. Strength testing of myotome sensory assessment. Check dermatomal points from C4-C8, including trapezius, shoulder, thumb, middle, and smallest fingers. Specialized tests. Conduct Sperling test, cervical distraction test, and upper motor neuron screening. Diagnostic imaging. X-rays for persistent pain GT few weeks, MRI CT for suspected nerve or spinal cord involvement. Red flags in neck pain: neurological and infection, progressive neurological deficits, and cervical cord compression, requiring immediate MRI assessment. Fever, meningism, history of immunosuppression or IV drug use, needs X-ray and MRI. Severe neurological symptoms warrant urgent medical attention and specialist referral. Trauma and tumor, osteoporotic fracture or traumatic falls require X-ray and possible CT imaging. History of cancer, with unexplained weight loss and night pain. Severe fatigue with suspicious symptoms, needs X-ray and MRI evaluation. Inflammatory conditions, rheumatoid arthritis presenting with severe joint inflammation and stiffness. Polymyalgia rheumatica showing characteristic morning shoulder and neck pain. Giant cell arteritis requires immediate rheumatology consultation and assessment. Yellow flags in neck pain. Psychological risk factors. High-intensity pain and disability without clear explanation causing significant functional limitations. Catastrophizing beliefs about pain and activity leading to fear of movement. Depression, anxiety, or post-traumatic stress symptoms requiring mental health assessment. Behavioral and historical factors. Passive coping strategies with expectation of treatment rather than active participation. Avoidance behaviors limiting normal movement and daily activities. Previous history of musculoskeletal pain indicating potential chronic pain patterns. Phases of neck pain. Acute phase 0 to 4 weeks. Initial presentation, characterized by sudden onset of severe neck pain, often accompanied by muscle spasms and reduced range of motion. Pain may radiate to shoulders and upper back. Primary symptoms. Patients typically experience sharp, intense pain, muscle tenderness, and stiffness. Daily activities may be significantly impacted, with difficulty turning head or maintaining prolonged positions. Recovery trajectory. Most patients show improvement within first few weeks with appropriate management. Important to maintain gentle movement while avoiding aggravating activities and monitoring for red flags. Acute phase, non-pharmacological treatment, treatment recommendations and monitoring, regular assessment of progress and treatment response throughout acute phase. Consider psychosocial barriers if improvement is not seen by month end. Focus on active participation and gradual return to normal activities. Acute phase, non-pharmacological treatment, active exercise and psychosocial interventions. Combined active exercise with psychosocial support reduces acute pain effectively. Early multidisciplinary treatment, less than 4 weeks, shows similar outcomes to usual care. Progress evaluation needed at end of first month for potential barriers. Acute phase pharmacological treatment. First-line medications, NSAIDs recommended as first choice, despite limited neck pain studies. Acetaminophen not effective for pain intensity or disability reduction. Consider patient-specific contraindications and risks with NSAIDs. Muscle relaxants, cyclobenzaprine, baclofen. Tizanidine effective during acute phase. Use short-term to manage acute muscle spasms. Monitor for side effects like drowsiness and dizziness. Alternative pain medications, tramadol or codeine as appropriate alternatives when needed. Follow 2017 Canadian guidelines for opioid therapy prescriptions. IV methylprednisolone not recommended despite some positive studies. Phases of neck pain, subacute phase 4 to 12 weeks. Symptoms and characteristics. Pain persists beyond acute phase but less intense, may experience stiffness and reduced range of motion, with potential muscle weakness developing during this period. Risk assessment, increased focus on identifying psychosocial factors that could lead to chronicity, monitoring activity levels and workplace ergonomics, evaluating progress of initial treatments. Treatment goals, emphasis shifts to active rehabilitation and gradual return to normal activities, addressing any ongoing pain concerns while preventing progression to chronic phase. Subacute phase, non-pharmacological treatment, psychosocial support and education, implementation of comprehensive psychoeducation programs addressing pain management strategies, stress reduction techniques, and workplace ergonomics while encouraging gradual return to normal daily activities with proper modifications. Exercise and physical therapy, progressive strengthening exercises targeting neck and shoulder muscles, combined with supervised physical therapy sessions focusing on range of motion and postural correction techniques for optimal recovery. Subacute phase pharmacological treatment, first-line medications, NSAIDs, ibuprofen 400-800 mg T or naproxen 500 mg, bid for 2 to 4 weeks. Acetaminophen 1000 mg QID as needed for pain management. Muscle relaxants, cyclobenzaprine 5 to 10 mg TID for muscle spasms. Second-line medications, low-dose antidepressants, amitriptyline 10 to 25 mg at bedtime for pain. Topical agents, diclofenac gel 1% applied QID locally, tramadol 50-100 mg every 4 to 6 hours for severe pain. Treatment guidelines, regular assessment of medication effectiveness and side effects. Consider gradual dose reduction as symptoms improve. Combine with non-pharmacological treatments for optimal results. Phases of neck pain, chronic phase. 12 plus weeks. Definition and impact. Chronic neck pain persists beyond 12 weeks, significantly impacting daily activities, work performance, and overall quality of life. May involve central sensitization and complex pain mechanisms. Common characteristics. Patients often experience persistent muscle tension, reduced range of motion, and psychological distress. Pain patterns may be inconsistent and influenced by various physical and emotional factors. Management considerations. Requires comprehensive biopsychosocial approach combining physical therapy, pain management, and psychological support. Focus shifts to functional improvement and pain coping strategies rather than complete pain elimination. Chronic phase, non-pharmacological treatment, exercise and physical therapy, structured exercise programs combining stretching, strengthening, and aerobic activities are essential for chronic neck pain management. Regular physical therapy sessions help improve range of motion and muscle function. Behavioral and psychological support, cognitive behavioral therapy, mindfulness techniques, and stress management strategies help address psychological aspects of chronic pain. These approaches improve coping mechanisms and reduce pain-related anxiety. Complementary therapies. Alternative treatments like acupuncture, massage therapy, and manual therapy can provide additional pain relief. These therapies, combined with regular exercise and psychological support, create a comprehensive treatment approach. Chronic phase pharmacological treatment. First-line medications. Acetaminophen 500 and 1,000 milligrams every 4 to 6 hours, maximum 4 grams day. NSAIDs. Ibuprofen 400-800 milligrams T or naproxen 250 to 500 mg bid. Muscle relaxants, cyclobenzaprine 5-10 milligrams up to TED. Second-line medications. Duloxetine 30 to 60 mg daily for neuropathic pain component. Pregabalin 75-300 milligrams divided bid for nerve-related pain. Amitriptyline 10-25 milligrams at bedtime, gradually increased if needed. Topical agents. Diclofenac gel 1% QID for localized pain. Additional treatment considerations. Short-term low-dose opioids only in severe cases. Regular monitoring of medication effectiveness and side effects. Conclusion and future directions. Effective neck pain management requires a tailored phase-specific approach combining both pharmacological and non-pharmacological interventions. Early identification of red and yellow flags is crucial for appropriate treatment selection. The management strategy should evolve through acute, subacute, and chronic phases, with increasing emphasis on active patient participation and multidisciplinary care. Future directions should focus on personalized medicine approaches, innovative rehabilitation techniques, and enhanced patient education programs to improve outcomes. Embracing a comprehensive approach for optimal neck pain management